Bismillah ar-Rahman ar-Rahim. This is an 83-year-old female patient who underwent PCI 2017 and received three stents, LED, RCS, and LCX. And then in 2019, she was diagnosed as sick sinus syndrome, tachybrady syndrome, and received dual chamber pacemaker St. Jude. And then in 2021, she underwent aortic valve replacement with a tissue valve, and the pacemaker was checked after the operation and was perfect. This is the interrogation of the patient. And as we see here, we can see that she's in sinus rhythm because we have here something we call AF therapy. This is the AF therapy as you see here. The patient is in, this is the interrogation of St. Jude, the first look. The first look of the device. This is the battery. Here you can see the longevity is more than 5 years, and there is no change in the vector or the curve of since 2019 till 2024. Here, when the battery is depleted, you can see this curve. This is not the case. Okay, so the battery is perfect, 5.7 years. Then we look at these are the programmable parameters, the DDD, lower rate, maximum tracking rate, and the paced and sensed AV delays, the A amplitude and the ventricular amplitude, and the pulse width. This is the resume of the patient. Then we look at the V pacing is less than 1%, the atrial pacing 97%. This is the graph of the percentage of pacing, and this changes every time you see it. Then we go to the mode switch episodes. As we see, there are many mode switch episodes. The last one, 19th of January, we are going to look at them now. You open them, you can see that there are automatic mode switch. Here, this is the beginning by an atrial premature, and the patient went into atrial fibrillation. How can we see? Compare with the atrial channel. This is atrial pacing, atrial electrogram, and native conduction, ventricular sensing. So this is perfect. Then she had this atrial premature beat, which drove her into atrial fibrillation. And this is how the machine here recognized that this is atrial beats in the refractory period, and according to the algorithm, so it is atrial fibrillation in the machine. And here is the automatic mode switch to DDI, I think, and we'll check that. And she was in this automatic mode switch with native conduction through the ventricle until it stopped here, and then she was back to atrial pacing and ventricular pacing after stoppage of this episode. So here we can look at here. This happened on the 19th of January this year at 4 a.m. in the morning, and it lasted only 14 seconds, and the atrial rate was 404 beat per minute. This is yes, we can see here that this is very correctly, and the ventricular rate, ventricular conduction, was at 74 beat per minute. Okay, this is the episode which happened this month. Then there is another episode which happened on the 3rd of September. You can see now we can see that there is an interference on the atrial channel, and the device recognized this as atrial noise, and that's correct. We can see here that in between these high frequency signals, we can see there are the atrial signal of pacing. So the machine was not affected. We can go here. Then here the machine says, okay, noise has stopped, which happened here. But actually the noise is still going on, and it was not recognized by the machine. In this area where the atrial sensing is followed by ventricular pacing. We know that the patient has native conduction, so this is false action. But after that, the machine recognized this is an atrial noise and stopped the automatic mode switch, and the patient is now in her atrial pacing native conduction. This noise is maybe from internal, external, we don't know, maybe from her movement of the arm, we don't know. We go to other episodes. This is the 30th of July 2023, and in this one there is atrial tachycardia. Again, it starts with atrial premature beat, atrial signal, A signal, A signal. This is about 120, and then faster, and then the atrial rate is going faster, and stopped here after 6 seconds. The atrial rate is 179 because this is atrial tachycardia, and this is good correlation. And here we have the machine is recognized it as automatic mode, as atrial tachycardia with the automatic mode switch, because we are giving. هنشوف احنا, we'll see how we are programming it. And then in the middle there was atrial sensing, ventricular sensing, and so forth. So this is another episode. Then 20th of July 2023. Now we can see there is some interference on the ventricular lead from outside. So there is some interference the patient is exposed to. We don't know where is the source. Sometimes on the atrial lead, sometimes the ventricular lead, maybe on because of subclavian puncture. This is why we like to have axillary vein puncture. Now again, this is an atrial tachycardia, very well diagnosed. Atrial rate 175, the ventricular rate is need of conduction at 70. Automatic mode switch worked, and as soon as it worked, to atrial pacing, ventricular pacing, it stopped. But the interference is still going in the ventricular chamber. Again here, January last year, 10 seconds. Again, here very well diagnosed as atrial fibrillation. The atrial rate is high. It's more than what we see, but it is at least atrial fluttering or atrial tachycardia, atrial flutter, and it stopped here. It stopped here. So these episodes, we saw it before because we have been following the patient since 2019 after implantation of the device, and we saw all these episodes. This is 2020. Here, the atrial rate is 179 again. This is atrial tachycardia with automatic mode switch. And we'll see this atrial fibrillation therapy now. AF therapy now. We'll see it from here. Okay, so we saw the episodes, but from previous ones, she had longer episodes than 6 minutes, and this is why we gave her anticoagulation. She has also a reason for anticoagulation with the tissue valve, of course. So we used the MAC, and according to her age, 83, we gave her 2.5 twice daily. Okay, this is the fast pass, as we can see here. Then we go to a test. For testing, we have sensing and we have capture. We look at the battery first. We have to update the data with the lead impedance, because we'll see how the atrial lead impedance is, yes, 350 and 490 for the ventricle. And you have here, we have to look at the impedance diagram or follow up all through this. It starts from March 2023 to March 2024 اللي احنا فيه ده. And there is no increase, no decrease, and the average is 350. This is very important because we saw interference. We don't know what this interference comes from. And this is the ventricular lead. It's all within the range. And here is 490, which is normal in a bipolar mode. Very good. Okay. Okay, now we go to the sensing. We'll do sensing for the atrium. We know that she is, we can check last session, which was today also, that she has intrinsic rhythm in the atrium, so we are not afraid. We can make the sensing here in AI mode A at 30A, and we run the test. She has normal sinus rhythm, normal conduction, and the P wave at 63 beats per minute, and the P wave is 1.8. And we have this sensitivity at 0.2, so we have safety margin of 5.5 to 1. So this is very good, very good. Okay, now we go to the ventricle. ممكن نوصل we have to connect for the ECG of the machine. إيمان بقى يلا. مش عارفة إيه. Now for the ventricle, we go to VVI. This is the best thing. We know that she has intrinsic rhythm, so we are not afraid, and we'll go start the test. Yes. We are connected the ECG so that we make capture test. We can see. This is, we will repeat the test because of the interference of the engineer. يلا يا ابني يلا وصلي يا إيمان. Again we'll repeat the test. بس كفاية لعب في سيرك. ماشي احنا كنا واخدين AVL. يلا إيمان. لسه وصل معايا لو سمحت. We are now going to test the ventricular lead. We are lucky that she has native conduction I1. We can change the limb lead as we want. We can check this by this. ماشي. Maybe lead 1 is better. لا, lead 2 is better. Okay, I will take lead 2. ماشي. And him. Okay, I like it. Okay, now we are going to do the test for the ventricular lead. Start, go down to 30. When you test for ventricular lead in VVI mode, you will the machine will ignore the atrial signal, so you don't look at it. It's not going to look at it. Type. This is the R wave is more than 12, very good, and sensitivity is at 2, so we have safety margin. You can look that there is some interference here on the EGM of the atrium. We can choose another. We can use a bipolar EGM signal. Much better. So we can play with the signal coming from the machine into the programmer here. Excellent now. Because we have bipolar atrial signal. If we go, you can choose it from the menu, this menu. I choose. It was unipolar tip, so there was some noise, whatever. We remember that she already has noise. Now we'll go the pacing capture test. For the ATM, we know that she has native conduction, so we can test in AI mode. And we can go now here at 90, pacing at 90. Yes. We will look at the pacing AP, and we look at the conduction on the ECG, and now 1 volt way. Okay, now, so the pacing threshold here is 1 volt at 0.4 millisecond in a bipolar mode. You can go back after recording like this. Here. We are testing for 2 beats. That's enough for an expert. If you are a beginner, you have to test for 5-6 beats to catch it. Okay. So the pacing threshold is the lowest amplitude which captures this chamber. It is here. 0.7 is not captured, so the one which captures 1 volt at pulse width 0.4 in a bipolar mode. Okay, now we go to the test of the ventricular pacing threshold here. Of course in VVI, because we have this rhythm. Now we'll go 1.5. This pulse width is programmed at, now we're starting, you can see the change in the, here, capturing, 1 volt capturing. Okay, this is fusion. So if we see this, you have to stop and you have to change into faster rate and start where you ended. So we'll do it at 100, 1.5 volt. Yes, 1.5. Capturing 1.25, 0.75 capturing. Now it's non-capture. Okay, so we'll see it here. It will come as EGM. Yes, here we can move with this arrow. And look, this is captured beat completely. This is fusion beat. So don't be deceived that this is not capture and this is conduction. No, this is fusion between the native one and the paced one type. Where is the one which we can say that there is no capture? This one, loss of capture here. Paced, beat, no capture. If you see that someone is captured, the other one is not captured, it is still not captured. So the threshold of the right ventricle is 0.75 at 0.4 in a bipolar mode. Okay, now we look at the parameters which we programmed, because I want to show you very important thing. So this is DDD pacemaker, lower rate 65, maximum sensor. We are not running the sensor. She doesn't need it. We have this maximum tracking at 130. The paced AV delay 225 as the sensitive delay. And here we have intrinsic ventricular intrinsic preference in order to minimize ventricular pacing, and we succeeded doing this. The VIP extension 100 milliseconds, searching interval 1 minute, searching cycle 1 cycle, and this helped us not to minimize the ventricular pacing as much as we can. The shortest AV delay 100 milliseconds, مش مشكلة. Now we have to look here. We measured we decreased the ventricular amplitude, our output, into 1.75 because it was capturing at 0.5. At what?
At 0.75.
Okay, so 1 volt above is okay. We can make it 2. Let's make it 2 better. It's not capturing, it's not pacing, so it's okay. And the atrium was
1 at 0.4.
So one safety margin is okay. And even the machine will tell you don't go down because you want to have safety margin. Okay. Now we have, these are the intervals. Post-ventricular atrial refractory period, post-ventricular atrial blanking period. This is well explained with Dr. Bayoumi. Sensing refractory for the atrium 93, for the ventricle 250. Here, this is very important for pacemaker-mediated tachycardia and PVC response. Pacemaker-mediated tachycardia response, I'm telling him, if you get it at 130 beats per minute, because this is a follow-up of this patient, we know that it had it some time, so go to atrial pacing at 130. After you see this, go to atrial pacing to stop it. Ventricular blanking period 44, ventricular safety standby is on, but we did not make the PVC response. Okay, no problem. If you don't know anything, don't play with any measurements until you understand it. Automatic mode, as I told you, when it is mode switch, automatic mode switch, it goes into DDIR mode, not to VVI mode. It goes into DDIR mode. This is why you saw atrial pacing in the automatic mode switch. The atrial tachycardia detection zone is 170 beats per minute. This one. And when it diagnoses it, it goes into atrial pacing, ventricular pacing at 70 beats per minute, and not following the atrial signal of the AF عشان ما يبقاش, because to avoid tachycardia. طيب, what is this function of atrial fibrillation suppression therapy? اللي هي بيكتب عليها AFX. This one. This is, I made it on, and when the sinus rate is coming faster then when there is a PEC or sinus is faster than the lower rate I'm at, like this one, 2 beats or 3 beats, he's going into the atrial fibrillation suppression for 15 cycles and is going to stop and see. Maximum AF suppression rate, don't go, and I'm telling him, don't go more than 90 beats per minute, because I don't want her to have this tachycardia. So this is, it will go here, and if it is still there, don't go more than 90 beats. 90 beats per minute is the maximum you go. Okay, this is what I wanted to know about dual chamber pacemaker, Endurity, MRI compatible, and if the patient goes into MRI diagnosis, so we have to go to MRI setting, do it DO, and choose the rate you want, maximum amplitudes, and this will run this for the test. After that, she comes and you go back to the standard. That's it. Thank you very much.